This is Emma Smizik, Associate Project Director at NICHQ. I'm going to go through a few housekeeping slides to begin with. So welcome again. Before we begin, a few notes. All participants have been muted on entry. Please do not place this call on hold, as we will be able to hear your hold music. Please use the chat box to the right of your screen for questions or comments, and we are recording this webinar.
Thank you very much. Good afternoon, everyone. My name is Krista Christakis, and I have the pleasure of serving as the Executive Director of the American College of OBGYNs here in New York State. And I'm pleased to welcome you to this webinar on opioid use disorder and pregnancy focused on readiness. ACOG represents OBGYNs and other women's healthcare providers across New York, conducting advocacy and developing education and patient safety tools to enhance women's healthcare in New York State. And I'm pleased to have two of our ACOG leaders here today to present on our latest project to help providers care for pregnant women with opioid use disorder. The slide deck being presented today by Dr. Kaufman and Dr. Gary has received accolades from across the country, being used by other quality collaboratives in their effort to address the opioid crisis. And it builds upon the National Council on Patient Safety's AIM bundle. So if you're interested in further information or grand rounds even, please reach out to us as we are offering that with our expert faculty. I also want to commend ACOG District II's multidisciplinary task force for their hard work and development of the slide deck, and to encourage you to stay tuned for our forthcoming slide deck at the end of the year focused on response. Finally, I want to give a big thank you to the Department of Health and NICHQ for sponsoring this webinar today. ACOG is really pleased to partner with the Department of Health on a new project on opioid use disorder and pregnancy and NAS, which Dr. Kasika will discuss in more detail in a few minutes. But before we introduce our faculty, I'd also like to turn it quickly over to Erin Bortel, a project coordinator from the Office of Drug Use or Health at the New York State AIDS Institute, who will talk about some important project updates that could be a resource to patients here in New York. So, Erin?
Hi, thank you so much for having me. So we at the AIDS Institute are coordinating a work group specifically to address the needs and barriers experienced by women who use drugs, which include women who are in treatment on methadone or buprenorphine, for example. We have some exciting initiatives that are underway right now. One of them is to develop clinical education modules that will specifically be offering free CEs to nurses. Another project is looking at a complement to the bundle that you're going to be introduced to today for non-clinical lay people, and we'll talk about how to best engage and retain women who use drugs and women who are in treatment in care, and how atypical social service settings like domestic violence programs and food services act as conduits to treatment and health care for women who use drugs. And the other initiative that we want to highlight is we are creating a work group which will report on findings and recommendations that will address barriers and challenges in identifying and treating expectant mothers, newborns, and new parents with substance use disorder. That's a legislative report and will be shared with both the New York State Department of Health and New York State OASIS commissioners, as well as the New York State Legislature. So if anyone's interested in participating, these are multidisciplinary projects by nature of the work group, and folks can reach out to me directly at the AIDS Institute, and I'm sure that Kelly and Krista can share my information afterwards. So we just wanted to share a little bit about some of the work going on at the Institute and support the good work of ACOG District II. So thank you so much, Krista, for having me today.
Thanks so much, Erin. Now I'd like to turn it over to Dr. Marilyn Kasika, Medical Director of the Division of Family Health of the New York State Department of Health.
Thanks so much, Krista. And I'm going to give a brief overview of a project that we have been working on and will be launching in the fall. It's a opioid use disorder and neonatal abstinence syndrome project. We've been working collaboratively with ACOG in Greater New York and Haney's over the last year, as well as the National Institute for Children's Health Quality. And what we plan to do is work with birthing facilities throughout New York State for approximately 18 to 24 months. And the the goal is to implement evidence-based interventions to improve the treatment and outcomes of pregnant women with opioid use disorder and infants identified as having neonatal abstinence syndrome. We're working collaboratively with a national project, the AIM project, which it stands for the Alliance for Innovation on Maternal Health. This is a national alliance, and it has many facets to it, of which this is one, and it's to promote consistent and safe maternity care to reduce maternal mortality by 1,000 and severe maternal morbidity by 100,000 instances over the course of 4 years. And the time period is 2014 to 2018. And I know that they just received funding to continue. It's funded through the Maternal and Child Health Bureau at the federal level, and it's designed to complement current maternal safety initiatives in progress. So it's to drive continuous quality improvement on the state and birth facility level. And as I mentioned, one of the key focus areas for this program is opioid use disorder. So with our state project, we want to improve the identification and treatment of pregnant women with opioid use disorder. And there are multiple ways that we intend on focusing on that through our hospital partners by delivering provider and patient education, implementing universal screening, improving the management of patients during labor, delivery, and immediately postpartum, coordinating discharge care, and collaborating across hospital teams to share and learn. And that's the obstetric side, and then we're also working on the neonatal side to improve the care of infants with NAS through many of the same drivers as far as provider and patient education, making sure we identify infants at risk early, improving the management of patients using standardized NAS treatment, which include both non-pharmacological and pharmacological. We want to make sure we coordinate their discharge care and make sure we share best practices across sites. Initially, we anticipate this to be like a pilot program, which we will be working with about 10 to 15 birthing hospitals in the state. And we will be inviting these hospitals based on both their interest, but also looking at their high rates of NAS in the populations that they serve. And we anticipate this recruitment starting within the next several weeks. This is the first project with our New York State Prenatal Quality Collaborative where we will be actually working on both obstetric and pediatric sides of the population in one project. So we think this will be very interesting. We'll be using the Healthcare Improvement Breakthrough Series model for learning improvement. And we work, currently on many projects with the same methodology that I'm sure many people are familiar with. When we work with facilities, we make sure that we work across disciplines, across the continuum of care, and we want to improve systems and process of care for mothers and their infants who are dependent on opioids. We'll have support from both national and regional faculty, including trained quality improvement, obstetric and pediatric specialists who are subject matter experts on OUD and/or NAS. And we will have both coaching and technical assistance, including in-person learning sessions, regular coaching calls, et cetera, to implement and test improvements with real-time feedback on data that will be submitted. We will have a project website that teams will have access to and a virtual learning community that will be used to share resources and engage participants. And we think that we have a real opportunity here to build quality improvement knowledge and capacity within facilities, which can be applied beyond the scope of this project. So I think we're very excited about this. I think we're learning a lot as we go on this topic. We have a lot of great experts within the state that you're going to be hearing from in this presentation and great partners at the table to facilitate this work. So at this point, I will turn it over to Krista. Did you have anything to add?
No, Dr. Kasiga, that was wonderful. ACOG is so pleased to be able to partner with the Department of Health and others on that project, and I think we should get right to the presentations. I'll briefly introduce Dr. Kaufman and Dr. Gary. Dr. Kaufman is the Associate Professor, Residency Program Director, and Vice Chair of the Department of OBGYN at SUNY Upstate. Dr. Kaufman has extensive ACOG committee experience, having served 2 terms on the National Executive Board, as well as 20 years on New York's Advisory Council. In that role, she served as 6 years as legislative chair and currently is the secretary of District II's ACOG's board. In addition, she serves as vice chair of CREOG, the Council of Residency Education in OBGYN. And, of course, she is the co-chair of ACOG District II's Opioid Use Disorder and Pregnancy Task Force. So welcome, Dr. Kaufman. Also, we have Dr. Gary, who currently serves as the Maternal Fetal Medicine Division Director at Stony Brook Medicine for the Department of Obstetrics, Gynecology, and Reproductive Medicine. He works with ACOG as a FASD champion in the effort to reduce alcohol-exposed pregnancies. Over the past year, he's also set up and established a maternal opioid management program at Stony Brook for the care of women with opioid addiction during pregnancy. And he serves as our other co-chair of the ACOG District II Opioid Use Disorder and Pregnancy Task Force. I want to welcome Dr. Gary and Dr. Kaufman, and thank you both for presenting today.
Thank you so much, Krista, and thank you so much to everyone who's on the call and for the tremendous collaboration that's going into all of this very much, the very important work that all of us that take care of patients on a daily basis realize is tremendously important in our ability to do so. We will share the website at the end of the presentation where everyone can get to the slide sets where you can go into much more depth. There are currently 80 slides there, and their plan is to have 380 slide set decks available to teams, hospitals, providers of all nature to be able to implement hospital protocols, EMR, set up office practice as well, many of the tools that we're alluding to, and a lot of the resources and a lot of the associated websites that went into the development of these slides. So we're going to start off with our presentation, but just mention that there's a tremendous tool that's there as well, and we'll give you those additional tools at the end of the presentation. So really starting off to set the stage of why this is so tremendously important. I think all of us that are taking care of patients on a daily basis realize that we are on a daily basis as OBGYNs. As an OBGYN personally, I'm taking care of moms that are withdrawing on a daily basis on labor and delivery, seeing them in my practice as well, and seeing patients with opioid use disorder on a daily basis, and it may not have been anything that I was necessarily formally trained in my residency in medical school, and we can't have an addiction specialist team that comes in, that swoops in and saves the day and takes care of the situation to handle the withdrawal or manages these patients, that it really takes a collaborative team to successfully and safely take care of these moms, babies, and families, and that's really the reason for creating all of these tools. The education you'll see is not exclusive to maternal opioid use disorder, that many of the approaches are very effective to any other substance use disorder, and we're going to talk about that quite a bit as well, that you'll see that there's tremendous crossover in the tools that you can use in the office as well as the inpatient setting. And each clinical setting is going to have to take into consideration what resources they have in making some of the decisions that we're talking about. So as we're talking about what type of practice you're going to be, whether or not you're going to manage all aspects, whether or not you're going to do a coordinated care with a medication-assisted therapy provider, or whether or not you're going to do the screening and then make that warm handoff to a provider who's then going to take care of the patient throughout the pregnancy and then transition her back to your practice. You have to realize what resources you have in the community, what social supports there are, and what resources there are at the hospital, because again, it takes a whole community to support these patients and these families. So what we've done with the opioid use disorder in pregnancy bundle is offer multifaceted education and tools, and elements that you can implement immediately into the EMR, but educational pieces to teach nurses, to teach residents, to teach providers, to teach physicians, and really all providers, including social workers, all providers on the team, how to better communicate surrounding patients with opioid use disorder, how to engage providers in all service lines who may have not been previously involved with patients with opioid use disorder. And this includes, as we had our first group that we brought together in our first summit to decide which directions to go into as we develop these tools, we realized that the justice system was a big part of this, that they were in some settings withdrawing patients from their medication when they entered the justice system. So education at many levels is very important to understand why things such as medication-assisted therapy are very much essential to the safe care of these patients. Enhanced communication with respect to common language, and Dr. Gary is going to talk about this in a bit, to make sure that we're not alienating our patients and our families with the inadvertent use of language that's not welcoming and in sending an unintended message to our patients that we want them to be sent away from the practices or our hospitals, and also enhancing family and patient education so that they understand what there is to be expected. Many of them have a fear of the child protective services that may be involved and will be involved around the time of delivery, what to expect should they be involved with medication-assisted therapy and what that would involve, what to expect with respect to withdrawal at the time of delivery, neonatal abstinence syndrome, what to expect at the hospital setting as well. So really knowing the basics and some of the first steps, what is opioid dependence? It's a physical dependence, physiologic adaptation of the body's presence to the opioid, and you define it when you have withdrawal symptoms if the opioid is acutely withdrawn. It is a chronic disease, and something that we want to really reinforce is that we need to view, and one of the real shifts in mind shift here with opioid use disorder is that this needs to be seen like other chronic diseases where it's going to have cycles of relapse and remission and needs continuous treatment, and we will see continued progressive associated disability or death if there's not treatment for these patients. And a chart that really brings this home that was published in JAMA in 2000 really reinforces the concept of this being a chronic condition. The first column is drug addiction with a relapse rate of 40 to 60%, but if we look at our other disease states that we commonly think of as chronic disease conditions such as diabetes, hypertension, and asthma, the relapse rates are really quite comparable to those other chronic diseases. So substance use disorders, again, I mentioned that the tools that we're going to be sharing with you will be translatable across many other use disorders, but there are many other use disorders that we see in these patients, and many times we're talking about patients who have polypharmacy. We're screening for many of these elements simultaneously in addition to opioid use disorder. And the use disorder, the definition of the use disorder occurs when recurrent use starts to cause a significant impairment, such as a health problem, disability, or failure. They're not meeting their milestones, whether it's at school or home. Additionally, with respect to opioid use disorder, in thinking of it as a chronic disease state, thinking about the volume of patients that we're now seeing. So in 2014, 1.9 million people had an opioid use disorder that was related to prescription pain relievers, and 586,000 had an opioid use disorder related to heroin use. So threefold the patients were associated with prescription pain relievers, and this is something that's quite startling, that we may think as we're seeing patients come into our units that this is secondary to heroin, or their first association is with an illicit drug, and for most of these patients it was a prescription that was associated with their chronic disease state currently. For the DSM-5 diagnostic criteria, you have that listed here as well. It's associated with having an increase in larger amounts of the needed opioid. For moderate to severe, you have to have 4 to 5 of these criteria, and 6, moving into 6 for severe, and they're listed here. We have videos in the slide sets, and we'll refer you to those as well on at the website. They are also very striking. The concept that really this hits anyone, this disease state, as all of us are aware as we care for these patients, that the face of opioid use disorder is not something that we can necessarily predict, and that's why we're advocating for screening all patients. Prescribing practices, again, how did we get to this point? In 2012, the number of prescription opioids was 259 million, and this was somewhat associated with the concept of pain being a vital sign. We had more than enough for every American adult to have a bottle of pills, and 20% of patients who had pain-related diagnoses that were either acute or chronic had an opioid prescription, as opposed to some of the alternatives that we'll talk about when we're talking about alternatives to opioids for pain prescriptions. And we can see the opioid-related deaths and treatments and admissions for opioid-related overdoses are increasing. So over time, we're seeing these numbers increase. This graph I find to be tremendously striking when we again think that the first contact may be or would rationally be potentially an illicit contact with the opioid. 53% of patients are saying that their first contact, the site where they were able to obtain their opioid, was from a family friend or from a relative. And of those prescriptions, and that you would think that, well, maybe they had a source, an illicit source, or this is something that was then obtained from multiple prescriptions built up over time. And when we split that out further, 83% were from one physician. So this is from the prescribing of a postoperative patient who had 60 to 80 tablets of opioids prescribed, and then were then given to the patient not for whom it was intended. And in New York State, the opioid-related deaths are also increasing over time, and we're seeing these numbers per 100,000 population. And what's very striking in this graph here, especially as a physician, I formerly practiced in the downstate area, currently practicing in the upstate area. What's very striking here is that this is very much a problem throughout the entire state. As we know, it's very much a problem throughout our entire country. But the graph on the bottom is New York City. The triangular graph is New York City. And the star graph at the top is New York State excluding New York City. So we see the highest numbers actually outside of New York City. The rate is actually twice that in New York State excluding New York City of the patients within the city. So tremendous numbers. And I'm going to turn things over to Dr. Gary for screening versus testing.
Thank you. Just as Dr. Kaufman mentioned, opioid use disorder does not adhere to any socioeconomic or racial lines. And so we have to approach this as screening should be universal. That the screening should be done with a verbal tool, and we'll talk about those tools later in the presentation. But understand that if you do drug screening or urine toxicology, that one test itself does not diagnose opioid use disorder, and that urine toxicology cannot detect all substances, specifically synthetic opioids, which is a problem that we see with fentanyl, and you have to ask for a special test to discover or to identify fentanyl in urine. Other tricks or things with when dealing with patients is to look at the state prescription drug program in New York. It's iStop, and when patients present, to just look them up in iStop and see what do they have prescribed to them related to opioids. So urine toxicology, depending on what state you're in, there are different requirements for consent or no consent. In New York, patient's consent is needed. I personally believe that you should explain to the patient what you're doing and get their consent. It shows that you're sharing information and makes for a better communication between you and your patient. Understand there are false negatives and, of course, false positives. And whenever a false positive arises, confirmatory tests should be done, typically at outside labs from whatever institution you may be at. Now, looking at ACOG screening guidance, ACOG clearly says that all pregnant women should be screened for substance use disorder. It should be part of the comprehensive prenatal care, and one of those techniques is using SBIRT, the acronym for screening, brief intervention, and referral for treatment. To think about SBIRT as sort of a conversation. You screen someone with a tool, and then you open a conversation with them. And this allows you to, in a, we'll say, friendly manner, because you're trying to communicate well with the patient, to discuss when she screens positive, what can you do and what information can you gather from them to assess their readiness for change and what treatment they may need. Additionally, in the appendix, there are some slides looking for that address the SBIRT system. Now, Dr. Kasika at the beginning mentioned AIM. AIM is part of the patient safety bundles, and New York District II has expanded this, and that's what we're looking at right now on the resources for expanding the summary of the existing evidence surrounding opioid use disorder. So treatment will be different depending on where you're located and what the resources of your individual institution may be. But they need to involve the patient, they need to involve the patient's partner, as many family members as the patient is comfortable with, and what other support services or support persons that the patient feels comfortable with to engage the patient in any way possible. Some questions that are commonly asked as I take care of many women who have opioid use disorder, and their questions are almost universally the same. First, am I hurting my baby? And the question comes up, and the answer is, from my perspective, I'm glad you're here for treatment, and now is a good time to make change, and we're going to avoid unhealthy behavior, and we're going to change your opioid use to another medication that we'll prescribe, and we'll keep you away from using things that may be harmful. So, and then, is medication-assisted treatment safe for your baby? The answer is yes, it is safe. Will your baby be taken from you? Because Child Protective Services is always a question that is brought up. And the answer that I give to patients involves staying in the program, making sure you're going to counseling, attending your prenatal visits, and being open and honest with all the providers that take care of you. And that will lessen the involvement of Child Protective Services and show that you are providing a good environment for your baby. Now, when it comes to communication of with patients, positive stories I've felt have been a very engaging thing with the patient, telling them that yes, there are others who have been through this situation, that they have been able to grasp a hold of the problems that they have and fight for to be on a positive, healthy line of life, and that they're able to have their baby, take care of that baby, and become unaffected by the opioids in their future life. So I do give them examples when taking care of them. Now, at each institution, you need to know what are the methods and what are the protocols available for taking care of the newborn. How is the newborn assessed? what are the breastfeeding recommendations at each institution, and what might be your scoring system. The most common scoring system across the country is called a Finnegan scoring system, but there are several others that are available. Now, as Dr. Kaufman mentioned in the purpose of our bundle here today, that one of the strong things in medicine, whether it's substance use disorder or taking care of hypertension or taking care of diabetes, is how to reduce stigma. And it's very prevalent in substance use disorders, particularly in opioids. And so we need to all adopt a common language. We need to say that if you're going to use language that is not a positive in nature, then the patient may not return for care. She may not be open and honest with you. She may not even be cooperative with what you're trying to say to them. And if you think about that personally, if you go to the doctor and you're sitting there and they are being very negative towards whatever the issue is that you're discussing with them, you're likely to not return to that person, or you're likely to not adhere to what they're saying. So if you think about it from a personal thing and you put yourself on the other side of the chair, I'll say, and be that patient instead of the doctor or nurse practitioner, that when you think about it the opposite way, learn to communicate using a good common language that does not stigmatize the patient. And this has to be throughout the care, whether it's the outpatient office, labor and delivery, postpartum units, or the nurseries. And we all have to be cognizant of what we're saying. We can't use language that may be negative. And some of those examples of the negative, the addict, that's a common one. And we need to really look at this and say, and I've adopted this myself, and do I refer to the patients as substance use disorder or opioid use disorder, whichever may be appropriate. And then when you're talking about getting clean, I look at saying you want a healthy lifestyle, that you are a former opioid use disorder. That type of language is quite helpful for communicating well with the patients. Being respectful, we'll say similar to the other side of the table. If you're a heavy-set person and obesity is your problem, you don't like to be referred to as a fat person. You might like to be referred to as maybe a large person or something along that line, which is less stigmatizing and helps patients to communicate better. Now we're looking at neonatal abstinence syndrome, which is essentially, in a nutshell, the withdrawal of the baby from the opioid exposure. That women should understand that this is going to occur. You should be open and honest with them and say that the baby is going to be held in the nursery, and that how long the baby is going to be held in the nursery is dependent upon several things. One is the dosing of opioids. Two is the concomitant medications, such as SSRIs for depression, tobacco use. They're probably the most common that may extend the stay for the baby. But they need to know the baby is going to stay in the hospital at least 7 to 10 days, maybe 10 to 14 days, depending on what their dosing of medication may be. Number two, that babies initially at birth don't show signs of withdrawal. It's not an initial thing. There's a slight delay, and it can be even a longer delay, up to 24 or 48 hours, depending on the opioid used. So understand that that's something to keep in mind when managing patients in the hospital. And lastly, we have to look at what are some positive things that help in the care of the newborn. One is breastfeeding, and breastfeeding should be encouraged in patients using maintenance therapy, and that women should be allowed to bond with their child and try and spend as much time as they can with them. And lastly is things that other concomitant things such as smoking, to try and reduce or eliminate smoking. Now, this data, which is goes up to 2014 and slightly lags where we are today, but is clear evidence that neonatal abstinence syndrome, similar to the slide that Dr. Kaufman showed earlier, the star is showing New York State excluding New York City, and you can see that neonatal abstinence syndrome, just the same as opioid deaths, is far more common in the suburban and rural areas throughout New York State. And this is something to keep in mind when taking care of women, especially in those areas where there may be less resources. Now we go down to the individual counties where neonatal abstinence syndrome occurs, and you can see in the very dark blue the higher rates in the upstate and western New York. And what do we look for, or what do providers need to know about what is neonatal abstinence syndrome? And again, as I said before, it's very simply the withdrawal of the baby. When I talk to patients about it, I will ask them, have you ever withdrawn? And then I'll say, well, that's sort of what the baby's going to go through, and why do we, and the degree the baby's going to go through it is the degree of opioid use, as I said before. But it involves high-pitched cries, poor feeding, tremors or shaking, and stuffy nose or difficulty breathing. Those are the main things that we see with neonatal abstinence syndrome. And I'll turn it over to Dr. Kaufman to continue with the plan of safe care.
Okay. So we also have to establish for these patients what's called a plan of safe care. And I mentioned before that this really takes an entire team. And for all patients, we're going to establish an entire team. So in the outpatient setting as well as the inpatient setting, this is not something that can be done spontaneously. It really involves team meetings, setting up policies for the outpatient setting as well as in the inpatient setting, understanding what resources you have in your community, and having good systems communication too, linking up the EMRs or having links into each other's EMRs as well, and establishing systems as far as how teams are going to communicate to best support these moms and babies and their entire families, as Dr. Gary mentioned, maybe defined in different ways how we can best support them. This includes social workers, case managers, legal services may be necessary in certain settings as we've outlined, and they need to establish what their plan is going to be throughout pregnancy, whether they're what type of medication they're going to choose, and what their plan post-delivery is going to be, how they're going to deal with this chronic disease state post-delivery, what's going to be their chosen therapy post-delivery, making sure that we have an effective prenatal summary that's communicating to the team on labor and delivery and postpartum and newborn care as well. And we'll talk a little bit about having them go to the hospital and have a visit with the NICU so that they know what to expect there as well, and having a safe plan upon hospital discharge, talking to the pediatricians as well, and having them meet representatives from these different disciplines throughout the pregnancy, including pediatrics prior to delivery, behavioral health, social workers on the outpatient side, anesthesiology, having them on board with a plan, maybe not having an outpatient consult with all patients prior to delivery, but having a plan for the patient for their labor, for their birth that's consistent with their wishes, and we'll talk about pain management in a little bit as well, but having your anesthesia team on board with a successful approach to having these patients comfortable with what it is that they need during the labor course, and having your nurses and your physicians on board with what's needed as well. Identifying a case manager to oversee the transition of the patients and the communication is really key as well, and having regular meetings to discuss cases and coordinating care management is also quite important for these patients as well. Understanding the plan of safe care requirements, the CAPTA requirements, which is the Child Abuse Prevention and Treatment Act. This is not new. It's been amended many times, but it's been in place since 1974. So understanding our requirements to report, and as Dr. Gary mentioned before, that CPS will be a part of the required reporting in order to have the most safe outcome for these babies, but we want the most safe outcome and supportive outcome for these families. And what's best for these families in many cases when they are successfully treated is to keep the family unit together. So having them aware of the reporting requirements, as Dr. Gary outlined earlier, is really quite essential. Having her a part of her plan in developing her plan for her delivery and her baby post-delivery, and making sure that you have the community support for breastfeeding, understanding that with medication-assisted therapy, breastfeeding is safe and that we're going to need to screen for depression. They're going to have increased risk for depression, and what resources are you going to have in place for management and treatment of depression if and when it occurs, making sure that substance use disorder treatment needs post-delivery, if your practice has been doing the medication-assisted therapy during pregnancy or it's a pregnancy-exclusive prescriber that then is going to have a warm handoff to a chronic disease state provider post-delivery, getting that set during the pregnancy, or if she's chosen to withdraw in a controlled setting post-delivery, how are you going to arrange that, if it's going to be an inpatient setting, outpatient setting, and which provider is going to assist with that. And the other essentials for having her baby, but a safe home, as Dr. Gary alluded to, CPS will assess, but looking for the home setting and making sure she has all the essentials to take the baby home as well. Additional elements in the outpatient setting in looking at practices, education for all staff. This is a wonderful opportunity for all staff to learn about how to successfully treat women with opioid use disorder and improve both maternal and infant outcomes, making sure that we're using universal terminology as we previously outlined that's welcoming and supportive for families, and how to get them to overcome their barriers. Teaching them, we have to start with our staff. We can't jump right into teaching patients and families. We will need to teach patients and families, but teaching our staff what medications are appropriate during pregnancy. So talking about methadone versus buprenorphine, which Dr. Gary will talk about in just a moment, but many patients and families, and for that matter, many of our staff, are not willing to think about chronic opioid during pregnancy, that this must not be safe. So understanding why in most situations this actually is the safest thing for her and for the baby, and understanding also what medications can potentially synergize opioids and would thus be increasingly unsafe to take while she is on her opioid therapy. Ensuring that all providers are educated about appropriate opioid prescribing practices, doing training with respect to enhanced recovery after surgery for all patients. So regardless of opioid use disorder, decreasing opioid prescribing across all patients, and looking at short courses of narcotics when we do prescribe narcotics, and doing training for residents, all prescribers of opioids is tremendously essential as well. Making sure that we have in place naloxone distribution and syringe exchanges for patients to reduce harm for patients and families, and educating patients with respect to administration of naloxone is something that we've also been advocating for, and ensuring that we increase education in our office practices as well, and collaborating with the pediatric providers so that they can have a plan for the newborn management management, as Dr. Gary mentioned, there are a lot of different tools to assess for withdrawal, whether it's the Finnegan scores or UConn has a system which many hospitals have adopted with soothing and decreased stimulation and increased swaddle for babies. So coming up with the plan and being a collaborative team along with your pediatric providers to determine the newborn management that's the most successful for your setting, for both your inpatient setting and your outpatient setting. Practices also need to have a clear approach to their screening, and then when they have a positive screen, how they're then going to move forward with testing, how they're going to operationalize screening, whether that means that all patients have an iPad to answer certain questions. It really needs to be in a private setting, so can't be that the secretary who introduces them to their visit, asks those questions up front, but is it going to be the nurse that brings them into the room? Is it going to be the provider that sees them that's going to ask questions? But how are you going to operationalize screening? Which tool are you going to use? Because there are many different tools that can be used, and there's a lot of support for the efficacy of the many different tools that can be utilized for screening. But all practices, the first step is to map out how you're going to screen, how to move then to testing, and then once you have that positive, how are you going to operationalize SBIRT and operationalize accessing your local resources. Educating all of your staff with respect to what the plan is, so there's never a question, so things move smoothly for these patients. Again, really explaining to staff, staff need to understand first why it is that withdrawing mom during pregnancy is not optimal, so that they can then educate patients and families why this is not optimal. This is an algorithm as to different models for practice approaches that different practices can adopt. Really, the second line that's there that's quite prominent is following a positive screen or disclosure of a probable opioid use disorder. Which direction are you going to go in? So this really, all practices need to be screening for opioid use disorder. There are three different potential options. One is that the practice, once the patient has screened positive for opioid use disorder, they're going to manage the patient through the medication-assisted therapy and all aspects of the OB care. They can also, as another alternative, co-manage with a medication-assisted therapy provider where they provide the OB care, and then there's a continued communication with the provider of the prescriber of the medication-assisted therapy, or they can only screen, and again, really pushing quite hard for all practices to be screening and then knowing what their resources are and referring to a practice that will then continually manage all aspects of those patients, but not stopping short of screening, making sure that all practices are screening and then referring out once those patients screen positive. So deciding which directions practices are going in is really a tremendous part of this. And then I mentioned very briefly before, but a very important piece of something that many of us are doing at our local institutions is ensuring that an appointment is scheduled prior to delivery to connect with these community-based services. It may be mental health services, but many are connecting with a pediatrician, and it may be a neonatologist as well on the inpatient side, so that they are aware of what scoring system. We have brochures for hospitals with respect to what the scoring systems entail, so that families can be a part of scoring their babies once they're delivered, and so that they know what to look for signs of withdrawal in the neonate. Additionally, another educational tool and an educational resource that we need to provide for all of our staff in the hospital setting as well as in the outpatient setting is the importance of trauma-informed care and having an environment of open communication. We do have resources with respect to this in the tools as well. And defining trauma-informed care and having someone in your practice educated with respect to trauma-informed care, understanding that the motivation for the entry to a use disorder, whatever that use disorder may be, in many situations was an underlying trauma. So understanding that the impetus for seeking that pain relief for that patient. So understanding and looking for the signs and symptoms of trauma in patients and families, screening all patients for physical and sexual violence in addition to the use disorders, and then coordinating with behavioral health and psychiatric teams is tremendously important. And then making sure that we have a setting that's welcoming, that's using appropriate language, and is avoiding re-traumatization for these patients, because we will then cause them to the avoidance of seeking care going forward, and the exact opposite effect of what we're looking to gain as far as the safety of mom and baby. So I'm going to hand things back over to Dr. Gary to talk about medication-assisted therapy and becoming a provider.
So I'm becoming a provider for buprenorphine. So my personal story, I came out to Stony Brook about 3 years ago and noticed that there was a number of women presenting to our labor and delivery unit in acute withdrawal. There was a number of women being seen in our offices utilizing heroin in particular, but also oxycodone. And there was a strong need, and it seemed that pregnant women were sort of not welcome at all the places that could potentially care for them simply because of pregnancy. So I took the course. The courses are available. There are various versions. There's online version. There's in-person versions. The American College of OBGYN, in fact, sponsors some hybrid type where you do some of the work prior to arriving there, and then you do the remainder at the location where they're having the training. So different things are available for both physicians and now nurse practitioners and physician assistants as of about 1.5 to 2 years ago that the rules changed around that. If you decide to become a provider, which I strongly encourage, one thing to keep in mind is that understanding your population, knowing how many patients are there, because I could not do it alone. So there are 4 obstetric providers that are buprenorphine providers and 1 nurse practitioner. And it is a great deal of, we'll say, relief to have someone else that can, pick up the ball when I have to go, visit my parents on vacation or something. I can't always be prescribing medications or seeing the patients. So it's important, I guess, to involve others in your office also. Now, when you compare buprenorphine and methadone, so understand right up here they're slightly different medications pharmacologically and how they react with the immune receptor in the brain. But up here we posted some of the benefits of each medication. And when you look at methadone, it's better treatment retention. There's no precipitation of withdrawal when you start the therapy, and initiation is fairly easy. Buprenorphine, you have less severe neonatal abstinence syndrome in the newborn. There's fewer drug interactions with buprenorphine. One of the main, we'll say, benefits is that it's not prescribed at any particular center, but can be distributed from an office of a provider who has the waiver. So there's a little less stigma around buprenorphine, and it can be done during routine prenatal care. And lastly, the overdosing for buprenorphine is, because it's an agonist and antagonist, very difficult to overdose with this medication. Now, when looking at another area that patients often bring up is, am I going to get, because I'm on opioids and I am taking medications that are opioids, am I going to get any pain relief when I come to labor and delivery or when I have my cesarean? And all of the people listening here and all the institutions, the answer should be your pain will be managed appropriately. understand that women who are opioid use disorders have upregulated pain sense receptors, and therefore they actually need pain medication, and to some extent, on a short-term basis, more pain medication than someone who's not an opioid use disorder. One of the things that is very helpful when patients show up, as I mentioned before, when they come to labor and delivery, is to confirm through the use of the state prescription program, the iStop in New York, to confirm what are the doses that these patients are on. So you can see any provider that has provided buprenorphine, methadone, et cetera, you'll be able to see this information, or any other opioids, if it's oxycodone or hydrocodone. In addition, when it comes to labor and delivery, that we make sure that our patients remain on their medication. So they'll remain on buprenorphine or they'll remain on methadone, and we'll provide the dosing through the labor process and postpartum. And this is recommended especially for patients undergoing, labor and undergoing cesarean. Now, all facilities providing care to pregnant women should really think about and look at how do they coordinate care. It's important to involve all providers, because patients don't just involve themselves with just obstetricians. So they may present to the emergency room for problems in pregnancy. They may present to the pediatrician's office. They may bring their baby to the pediatrician's office and have a complaint there. So you really should understand, and all the providers should understand what's going on with the hospital. At the beginning of the presentation, Dr. Kaufman showed us that prescription oxycodone is one of the largest gateways to the use of opioids and then opioid use disorder, and that prescriptions for pain and pain as a vital sign has led to this. So in response to that, and how we have to take care of this in the future, is to having on discharge short dosing periods, say 3 to 5 days, although the slide says 7 days. I provide it even shorter and have the patient call my office if they need more medication. So not to provide 200 tablets of oxycodone after a cesarean, but to limit to a 48-hour or 72-hour dosing. Now, establishing coordination of care, the programs need to meet the patient and family's resources needs, and it's important to sort of have a team approach to this. You have the obstetrician provider, whether it's a physician, a midwife, nurse practitioner. You have nursing involved, you have social work involved, you have pediatricians involved, and so they have to sort of coordinate the care. And it's difficult because we all move in sort of different circles in caring for patients. So you have to make some effort to coordinate care with patients and have open communication so that, one, the patients feel good about their care, and two, that there's no, we'll say, misinformation that goes on with patients. And thirdly, when you look at the community health areas and community networks that are available, each part of the state has various resources available. You have to take a look at your own personal resources. One example we know about is in Broome County. They have the Baby Basics program, which helps provide support for the newborns and their moms. Now, understanding that the Child Abuse Prevention Treatment Act, or CAPTA, for your state and county is important, and who has to be, when substance-exposed infants are born, who has to be reported and who doesn't, and what does CPS at every institution mean. This is a struggle, actually a very big struggle across the state of New York, and I believe in other states as well. It is how to coordinate Child Protective Services with the care of the mom, the care of the newborn, and trying to coordinate that no harm comes to either the mother or the baby in either direction, meaning that we didn't refer them to Child Protective Services and some unforeseen event occurs, or two, that there's a hardship placed onto the family because of CPS involvement. So trying to work with the CPS at each institution is important. Now back, looking at screening and evaluate all pregnant women for opioid use disorder. I think this is a common theme that you've heard from Dr. Kaufman, mentioned it several times. I've mentioned it. So it's important. And also other things that are outside of just screening for opioid use disorder, but things that are very common in this population, which is the psychiatric disorders, sexual violence, infectious disease, and I'll say especially hepatitis C. And made a very big effort here in our practice in Suffolk County to screen for hepatitis C. Important now because it has a cure rate that if you can get patients in for treatment. Number two, the office setting for prenatal care is probably for intake the most probably the most important, because they get the first impression of your practice, the first impression of you as provider or you as providers, meaning that your nurses, your nurse practitioners, and everyone who's in your office. And then also putting in the screening tools at that time. In the hospital situation, when patients arrive for either emergent or urgent care for suspected labor or some pain that they're having, being able to screen them when they come into the emergency services, and of course screening in the labor and delivery unit. Now what tools? There are several tools out there. I personally think that the 4 Ps is probably one of the better screening tools. Audit C, another choice. The NIDA Quick Screen and CRAFT are available. My advice is for anyone to just pick a tool and use the tool, because screening with some tool is better than not screening at all. And yes, no answers, we're well aware, don't work very well. So very important to use some kind of a tool. The tools, of course, should be non-judgmental and open-ended, which the ones that I mentioned are very much that way. Brief intervention is sort of a conversation. That's how I look at it. I screen someone, they report that their heroin use, and my conversation with them is similar to, so you have been using heroin, how much, how often? We'll go through that. And then, of course, it's now, where are we headed with this? And their response, would you like to consider inpatient therapy or outpatient therapy? Inpatient would be anywhere from 72 to 48 hours to up to 2 weeks if necessary, or outpatient therapy. So we can offer them either of that. What is their readiness for change? And that's what you're assessing. So you're listening to them, you're responding to them, you're acknowledging what their problem was that they screened positive for, and then you're thinking about referring them for treatment. And of course, the referral for treatment, of course, depends on, one, their readiness to accept some treatment, because for me, women who don't want to help themselves, they don't want to go they don't want to go to inpatient therapy, or they don't want to attempt outpatient therapy. If they're going to just return to their unhealthy behavior, I can't help them. It's when they're ready to make the change is when I can help them. And then, of course, it's the assessment for this referral for treatment, and I happen to have the options of both inpatient and outpatient. So in your particular areas, you just have to assess what's available for the various needs of the patients, and then be able to describe that to the patients when they when you encounter them and they need referral for treatment.
Okay, so we're going to move to the hospital approach, and understanding the hospital approach is an important part for providers that are delivering and working in a hospital setting. If you're a team leader and you can impact the philosophies of your unit and your hospital and your collaborative team between peds and postpartum and antepartum, having this be a coordinated group collaborative prepared plan in advance is tremendously important. So understanding what the federal reporting requirements are, as we've mentioned a few times, is going to be very important for education for all providers. And some of the team members that we mentioned before in the hospital setting that are going to have to be educated and on board with our plan are nursing, social work, the women's health care provider, be it an OBGYN, nurse midwife, hospitalist, the residents, the medical students, the nursing students. We have to all be using sensitive language and appropriate language that's welcoming and supportive for these families for the best outcome, and on board with our plan. The anesthesiologist, and we're going to talk about options to keep these patients comfortable, but the anesthesiologists have to be on board with our plans as well, and the neonatologist for both outpatient visits and also inpatient. As a team, what tool are we teaching the families about that we're using for the scoring for the neonatal abstinence syndrome? What have we adopted? What's the best for our hospital philosophy, and that we're introducing to our community as our tool for assessment of withdrawal. And behavioral health specialists, this can be tough on the inpatient setting, on outpatient setting. It may be the primary provider that's been caring for the patient, but we need to know that because we're going to be screening, and when we screen, we're going to have positives. So what are we going to do? And the emergency department needs to be educated as well. They're going to be seeing withdrawing moms as a first line. They may present to the ED. We need to have a philosophy as far as how we approach these patients. Dr. Gary mentioned before with respect to some of the elements for pain management for patients that are coming in labor and not in acute withdrawal, but just for their management. We have to have a protocol for how we address opioid use disorder, and understanding that these patients have an increase in their pain, they have increased sensitivity, and they may require increased doses of opioids through their pregnancy because of increased tolerance. We need to maximize non-pharmacologic therapies, and this is true for all patients, and I had touched on that before, but enhanced recovery after surgery, non-pharmacologic therapies is true for all patients across the board without opioid use disorder, but tremendously true for the opioid use disorder patients as well. Physical therapy for if they're having low back pain in pregnancy, rather than going straight to increasing their dose of their medication-assisted therapy, thinking about physical therapy, thinking about not in pregnancy but postpartum NSAIDs, and avoiding mixed agonist-antagonist when they're going to be coming in labor, and sharing the withdrawal order sets, which Dr. Gary is going to talk about withdrawal, but sharing them between institutions so that we have a withdrawal order set in management with anesthesia and with peds so that everyone's on board with our philosophy. Having a philosophy, a flow sheet with respect to how we're going to manage these patients when they come to the unit is tremendously important, knowing whether or not they've had prenatal care, whether they've had medication-assisted therapy, verifying their dose. We're fortunate in New York State to have a system that works to go into iStop and be able to verify their dose. We may be coordinating EMRs with their provider that provided the medication-assisted therapy, but checking their prenatal care, the documentation there, their medication-assisted therapy as well to optimize their management in labor. I've heard many times delivering patients on labor and delivery that the patient in whatever room who has an opioid use disorder just got her Suboxone. She just got her methadone. That should be sufficient for her intrapartum analgesia. She's only 2 centimeters. She just got her Suboxone. We don't have to think about giving her additional pain medication for her painful contractions as we're inducing her or she's in early labor. We need to realize that that's her chronic pain, her chronic medication. Just like a patient who has preeclampsia comes in and has an exacerbation of her hypertension, we're not going to withhold her baseline chronic hypertensive medication, such as her baseline oral labetalol, and not push IV labetalol or hydralazine when she has hypertensive crisis associated with preeclampsia. When she comes in and she's in labor, we are, as Dr. Gary mentioned, they are at Stony Brook at SUNY Upstate, where I'm delivering at Krause Hospital. We are continuing their baseline medication-assisted therapy in labor and then giving them additional analgesia as needed on top of that. So that should be continued throughout their labor, understanding that neuraxial anesthesia is safe, that we may see hypotension, so be prepared for hypotension potentially, and I mentioned before we have to avoid mixed agonist-antagonists for these patients. And talking to anesthesia, getting them on board with respect to other options for these patients. And here, particularly, we're talking about tab blocks. They may not be practical for all patients on your unit, but particularly for patients where having a morphine PCA or giving them opiates or higher dose opiates or trying to minimize the amount of opiates that they have for pain control postoperatively, say if they are an obligate C-section or they end up having a C-section, having a tab block to reduce their postoperative pain requirements can be very helpful. Giving them Toradol as well, and again, understanding that they're going to have more pain and they're going to have higher than average opioid doses when you start treating them with opioids. Using heat as well, again, optimizing those non-pharmacologic pain treatments, and encouraging patients that are postpartum to breastfeed, that there's not a contraindication there. If they've been on methadone or they've been on buprenorphine, if they're interested in breastfeeding, we should be encouraging them for the best outcome for baby, for them to be with breastfeeding. And I'm going to turn things back over to Dr. Gary for withdrawal.
So when dealing with acute withdrawal, it comes in various levels. We all, I'm sure, have experienced the patient withdrawing in our labor and delivery unit, which may be some of the most severe withdrawal, versus maybe in your offices some mild withdrawal. To begin with, the management of withdrawal is very basic, meaning what are the vital signs, particularly respirations. And it is in that the assessment of the vital signs, if you're lacking respirations and you're unresponsive, the need for naloxone, or its trade name Narcan, needs to be administered. That's administered nasally and or subcutaneously, and to bring back this patient from her and block the opioids. And allow her to, she will start acute withdrawal after receiving naloxone. However, you're reversing the opioid effects immediately. With respect to the remaining management of that, the subsequent bundle that ACOG District II is working on right now is looking at the sort of a overview of the management of withdrawal, both acute withdrawal and taking care of patients in the office, with respect to some mild withdrawals. And these are all based on, the severity is based on the Clinical Opioid Withdrawal Scale, or the COWS scale, which is available in the appendix, that looks at the features. Are they sweating? Do they have stuffy nose? What's the heart rate? What's the breathing rate? And those are sort of all the different components physically that go into the withdrawal, opioid withdrawal scale, or the COWS. But our subsequent bundle will come up with some examples of some dosing that can be used or may be used in the management of acute opioid withdrawal, because that is a common question that many ask, and how to take care of these women in the labor and delivery units throughout our state. Now, understanding what's available not only at your own facility, but the surrounding area is important. Understanding that many of these women also will be drinking, and alcohol is an important component that needs to be addressed with substance use disorder. And knowing who can provide addiction services, so counseling for opioid use disorder or counseling for substance use, whatever the substance may be, understanding what's available in your area. The OASIS, New York State OASIS Treatment Center services, they do in fact have one, a line to call, and two, they have a find a treatment. And I actually checked on this, and it does, the ones that they say exist, at least that I checked on, do in fact exist. So we have to thank them for all their services. And of course, being able to arrange things for patients to be able to get to care. A patient that we just discharged from the hospital recently, we had to arrange for care for her to be able to receive methadone. She was on methadone, we continued methadone. So in order to get her from her place where she was living to the methadone facility, needed a cab ride. So we needed to arrange for this. We needed to arrange for the methadone to continue at the current dosing. So things have to be arranged in the background for these patients in order to maintain healthy behavior for them. Overall, what you should take from this presentation is that screening is a part of comprehensive obstetric care, and it should be done at the first prenatal visit or the first time you encounter the patient. Two, that language helps reduce stigma. It helps reduce stigma in all aspects of medicine, and it helps promote evidence-based treatments and demonstrates that you actually respect the women you're caring for. That specific prenatal, intrapartum, and postpartum pathways for women with opioid use disorder need to be put in place, and that individuals should understand what's available at your facility, what's the policies and protocols that exist at each of your own facilities, and that we do have resources which are attached at the end. There's quite a number of resources. At least on behalf of myself and Dr. Kaufman, I'd like to thank all the individuals, because there's quite a number of people who have been part of this, and they often go unrecognized. And at least you can see here on this list the number of individuals that have helped coordinate this. And I'd especially like to thank Kelly Gilchrist for what she's done in spearheading things at ACOG District II, along with Krista Christasa, I can't say her last name, Krista, sorry, that with respect to what they have spearheaded through New York, through District 2, and I do appreciate it personally. I'll turn it over to Leah.
Yeah, I think we were going to then open things up to questions.
Wonderful, thank you. This is Krista, everybody. Our colleagues at NICHQ, I think, are going to help us facilitate some questions to hopefully get your questions answered, and if we cannot get all your questions answered, we can certainly take those and try to answer them offline.
Great. So if you have any questions, please feel free to press that raise hand icon, and we will be able to see that, and we will be able to call on you and unmute your line. While we wait for folks to raise their hand, there were some questions that came in through the chat box, so I'll just read off some of those for the presenters. What are your thoughts on the 4 Ps verbal test?
I just speaking, this is Dr. Kaufman, speaking personally that it is a great tool to be using, and it's an easy to implement tool as well, and that all of the tools that we suggested, that they've all been studied, but not one tool has been validated as the gold standard for a tool for screening. So if that's a tool that can be easily implemented in the inpatient setting as well as outpatient setting, that absolutely that I would support utilization of that tool for screening.
I too, my favorite tool happens to be the 4 Ps, but I think any tool that you use is important, not just not yes, no questions. So to utilize a tool is very important. Each of the tools has their positive side and their negative side. And as Dr. Kaufman said, there's no one tool to be used right now.
Great. We had a comment that came in, not sure about New York, but in Massachusetts, the NAS diagnosis automatically qualifies for early intervention for the newborn.
This is Chris Cuss from New York State, and currently NAS is not an automatic qualifier for EI.
Thanks, Dr. Cuss.
Thank you, Dr. Cuss. Another question that we had, does buprenorphine, I'm going to say that wrong, buprenorphine. Thank you, provide any pain relief?
So buprenorphine is a opioid agonist and antagonist. It does provide some pain relief. It is not a great medication for the use for pain. Oxycodone, actually methadone, are much better medications for pain, but it does have some pain relief properties.
Great. Another question. I saw at the beginning the justice system would be part of the team approach. Not seeing follow-through for that piece of the team, will there be algorithms for how to screen, treat, report in the different settings?
So there are a lot of tools in the toolkit on the online resources, and a lot of links to websites as well that outpatient settings as well as inpatient settings can implement as EMR order sets and, as Dr. Gary mentioned, the COWS withdrawal assessment scoring system and practices and different settings can pull from different really pull their needs into their different settings. The algorithms as far as how to screen are the same in all settings, and treatment will be the same in all settings. The point that was made when we had our initial summit and made it into the white paper that was written subsequent to that with respect to opioid use disorder and pregnancy was that the patients were withdrawing when they were entering the justice system, and they were being taken off their maintenance therapy because the sense was for those that were in direct contact with those pregnant moms that they were using an illicit substance and they needed to be withdrawn. And so we are continuing education in that setting. So I think that's the piece that's needed at this point is enhanced and continued education of those that are taking care of patients in the justice system, so they understand why, just like the education is really the same as what we're talking about for our patients, our families, our nurses. Why MAT? Why not withdrawal? So we need to educate in those settings. But to answer the question of will the tools and the algorithms be different, they're really the same across all of those settings.
Another question, is Nubane a good option for pain relief for patients in labor?
Now bufene, which is Nubane, it's an opioid agonist antagonist, the same similar to buprenorphine. I would just be cautious that if someone is opioid user, opioid use disorder, and you're administering Nubane, you could precipitate withdrawal. So one has to be careful with that medication.
Another question, does a positive screen for marijuana contradict breastfeeding on a maternity unit?
I would just say briefly no, that it doesn't.
I'll answer that with marijuana continues to be a area of controversy. There are several articles that just recently came out about marijuana use and long-term outcome of babies, and there's nothing clear that says this is exceptionally harmful, and there's nothing clear that says this is completely harmless. So we're sort of stuck in this place right now that is to be determined. Our hospital is not, in women who test positive for marijuana, we are not, we'll say, encouraging breastfeeding, but we're not discouraging it either. But I don't know how to best say, how do you walk the middle of that?
Another comment that just came in, NICHQ is also a valuable tool for prior history of ER visits seeking meds. And another question, is there a side-by-side comparison of the various screening tools with positives and negatives? That might be a helpful review for us to choose.
Yeah, actually there is a, I can't remember what the publication is, but what I can do is at least get it to District 2. Maybe we can include something in our next bundle or send it out to the people, to all the listeners here. But there is a chart that puts together many of the tools with their positives and negatives and what populations they've been tested in.
Great. Going back a ways in the chat, there were some questions that came in at the beginning of the presentation. One question was, is the training you mentioned for medical providers, can it be for home visitors?
I'd say absolutely, that it's the training is appropriate for all levels of contact within the team, and the tools are meant to reach all levels of providers.
I'm referring to an early slide. Someone said, I see this is for age 12 plus. What % of opioid users are teen parents?
I don't know that answer off the top of my head.
Yeah, to come up with a hard percentage, I can't say that I can come up with a percentage either.
And we just had another comment come in. There is a NIDA study in progress comparing verbal screening tools and has not yet been completed. Those were all the questions and comments that we've had so far. I don't see any hands raised at this time.
Well, thank you very much. I want to thank our presenters, Dr. Kaufman and Dr. Gary, for a wonderful presentation. Thank NICHQ and the New York State Department of Health for helping to sponsor and run the webinar for us today. And I think this webinar is being recorded. Am I right on that, NICHQ? And we'll send out some follow-up information?
That is correct.
Wonderful. Well, thank you, everybody. I hope you have a great afternoon.